Welcome to the Codecast Podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast Podcast. It is May 19th, 2020, and we are at the 135th episode. Hopefully, if you had a chance to take a walk or go to the beach, if yours is opening, as ours has here in Southern California, or at least get outside for a hike or just a walk to the end of your street. But please don't be afraid to go outside. We have flattened the curve. States are slowly reopening, and we're heading towards phase 3 in some places. I know some places are still in phase 1 and 2. But just be safe. Throw a mask in your car for grocery shopping or to pick up wine. Yeah, I said it. I miss my wine club. But just try to get out a bit. We are allowed to do that in all states. Read your guidelines. And just keep something in mind here. Remember, the quarantine stay-at-home rules were to flatten the curve, not to cure COVID. It can't be cured. It's a virus. They're trying to work on a vaccine, but we're trying to flatten the curve, and we have flattened the curve. According to CDC.gov, 98% of anyone who's contracted it, as I did back in January, has recovered. So just want to make you aware of that. And everybody's good who has contracted it and recovered. So I know there's been, obviously a percentage of deaths, but it's less than 1%. So let's just keep that in mind as we go forward. If there is any kind of positive as far as certain viruses, diseases, things that we catch, things that people get, and we just have to always put things in perspective. So trying to find a little bit of a lining in the end of this. So anyway, this week I will need to bring you some new information to light that came to me from a colleague of mine, and actually a close colleague of mine. So shout out to Barbara Kabuzzi. Barbara and I served on the AAPC National Advisory Board together in the early 2000s. Barbara and I have known each other for a good part of over 20 years. Our kids are around the same age and now adult children. And she is an otolaryngologist, specialty coder. And also, just like me, she has been diving into telehealth most recently. And I really like how she's worded some of her AAPC articles. So we're also friends on LinkedIn, and we were talking recently regarding the 95 modifier and incident 2. That is a thing, believe it or not, in telehealth. And I've been struggling trying to figure out how that could possibly be a telehealth option because, as you know, incident 2 is a Medicare rule as far as the physician being in the office, and then certain staff can provide services and bill it under the physician. But in telehealth, since a lot of those services are under the visit codes for office visits, even the level 1, how does that work if you're not in the office? And so, there is a limit to what telehealth can do. So we were really talking about this and trying to figure out, even I was talking to my daughter about this, and I was thinking if this was a Zoom audio video call, the doc could be invited and available from a distant location, their home or office, and jump on the call if necessary. But what if this was a FaceTime or Skype or other allowed platform? It's easy with Microsoft 360 Teams, that's the next gen EMR, or MyChart with Epic, because you can bring anyone in. But how do you apply it again when you're not in the same location? So to me, that's not incident 2, and the doctor's not on the call. And if they are on the call, then why would they need the ancillary staff to do the work? So, and the reason this question came up to me and why I even pursued it, because I know this has been a discussion over the last month, is because I saw one of the FAQ updates that incident 2 is allowed for an audio and video E&M, and on the CMS office calls that they have, those calls twice a week, on May 14th, so just last Thursday, a question came in and asked if RNs, not medical assistants, but RNs, can now report the 99211 under telehealth. So if they're doing blood pressure checks or, any kind of blood draws for specific reasons, not just the blood draw. But again, an RN, because they can't bill a regular office visit, they can't do an assessment and plan under an RN. And can they do that? And they basically said, yes, they can under incident 2. And again, I'm thinking, well, how is that even possible? Because they can't report directly to a payer, so they would have to report it under the physician. So Barbara and I got into this discussion on LinkedIn, and her take from the gist is what's being inferred under the IFC interim final rule. And that is that during the public health emergency under the PHE, incident 2 has become more of a general supervision instead of a direct supervision. But all it says is your physician needs to be available, and I'm air quoting right now, by audio and video to jump on the call if needed. So they don't call it general supervision specifically. Their wording says physician needs to be available. So again, the feature of inviting a physician should be there, but I would put some kind of entry in the note if you are doing any kind of nurse visits or anything like that with your RN, that it was incident 2 for this doctor as covered under telehealth PHE language under the interim final rule, and that should cover you. That's the only thing that I think would be, appropriate in this scenario. But you have to realize that because the rules have been so flexible right now, this is where this question, kind of comes up, and trying to figure out how to navigate through it. We were also talking about the 95 modifier, because one of the things that I've stuck to my guns on this, the 95 modifier, if you look in your CPT book, it is pretty clear what the definition of the 95 modifier is. It says synchronous telemedicine service rendered via a real-time interactive audio and video telecommunication system. And it goes on to just be very clear about telecommunication via audio and visual. But our conversation, Barb and I, when we were talking about this, I said the problem I'm having is that people keep asking the question for phone call only codes. Is there supposed to be a modifier? Because I do see offices getting paid for those when they use the place of service 11. But I'm not noticing if there's a difference in parity in the price and the reimbursement, meaning that, remember, we got a increase from $10 to about $45 to $45 to about $110. And so that's a big deal. But when they opened up the phone calls for payment, this question came up, and the answer was no, don't amend a modifier. You don't have to. But then now CMS changed their mind again on the 514 office hours calls, saying that they added phone calls to their list of telehealth services, that they consider the 95 the telehealth modifier, while ignoring the CPT definition. So all codes on that spreadsheet apparently require the telehealth modifier if reported via telehealth, audiovisual or not. So how Barb and I were talking about this, and how she put it to me, and this was good wording, I thought, is that it appears that CMS, Medicare, is co-opting the definition of the modifier. So they're basically saying they're ignoring what CPT says and using it for their own definition. And I'm not excited about this direction, but I heard it myself on the call. So if you are providing phone call codes, which would be audio only telehealth, and I'm saying as of today, so we're dealing with May 19th, but it looks like it's going back probably when they were first opened up in April 6th, the 95 modifier should be appended. Now that list didn't come out until April 30th. And so I would just do it from this point on, as far as making sure that you're compliant, because that's what they're telling you to do. So hopefully CMS will add it to their next FAQ sheet, not just part of their replay of those calls. They have their replay on podcast. But I wonder again if this is tied to payment parity. And if it could be, then you want to make sure that you're using it as a Medicare directive under the PHE. So I know I've been saying for the last 3 podcasts in May, I did not want to keep talking about telehealth, but I think that was me being hopeful that the pandemic and the PHE period would end soon. So as long as there are updates and questions, I feel I need to bring it to your attention. So if you're sick of hearing it, I'm sick of talking about it, but it's important for you to have the information. So hopefully you found that helpful. So our coding question today actually has to do with a patient who is now coming in follow-up for a resolved COVID patient. So what should be coded for that from an ICD-10 perspective? So I reached out to the coding clinic and the AHA, so American Hospital Association, because they give us direction on how to use the I-10 codes. And they said to use the generic follow-up code Z09, encounter for follow-up examination after completed treatment for condition other than malignant neoplasm, and history code Z86, Z as in zebra, 86.19, personal history of other infectious and parasitic diseases. So based on this guidance, this is there because the patients with a history of COVID-19, there's no ICD-10 code for personal history of COVID or viral infection. So that's the only thing that I can basically direct you to do, because we have it in writing from the coding clinic to actually do it that way. The other thing I wanted to bring to your attention, and hopefully you'll find this very helpful, There was an announcement made that starting on May 6th, so last week, the HHS, so Health and Human Services, will start accepting claims for encounters dating back to February 4th for patients that are uninsured. So it's called a COVID-19 Uninsured Program Portal, where you can register and submit claims. And that's part of the Families First COVID Response Act, the FFCRA, and the Paycheck Protection Program and Healthcare Enhancement Act. There was $1 billion each of them got for treatment of uninsured patients, and additional funding is being allocated by the Coronavirus Aid, the CARES Act. So in general, the steps involved in obtaining payments for uninsured encounters will follow this framework. So first of all, you have to enroll as a provider participant. You do this through a system that's actually being administered by United Healthcare. That's the contractor working with HHS to distribute the provider relief funds. But you want to go to coviduninsuredclaim.linkhealth.com/get-started. And I'll have this on my website and a blog by the time you hear this. And then you want to set up Optum Pay. This is a direct deposit mechanism to gain payments. It takes about a week to get it in place. And then add your provider roster. So only one person per TIN number can serve as the program administrator. So you want to coordinate your efforts across your organization, especially if you're a very big clinic. And then this is temporary. Add your patient roster. You need to show that you've confirmed the patient's uninsured status. Specifically, you have to verify that the patient does not have coverage such as individual, employer-sponsored Medicare, Medicaid coverage, and no other payer will reimburse you for COVID testing. And then you submit claims for reimbursement starting May 6th. For professional claims, actually facility as well. But just know that HHS says it will pay claims at a rate on par with Medicare, but eligible claims must involve a patient with a COVID-19 diagnosis. So if it was suspected, those will go to the end of the list. If it was a patient was confirmed and was treated and was uninsured, that's what this is for. So that's going to be definitely an important fund for you as you move forward. Okay, our coding question was brought to you today by Advanced MD, cloud software for independent medical practices that delivers industry-leading patient outcomes and financial performances. Also a leader in telemedicine modules, advancedmd.com. Also, if you are expanding your practice into telehealth and you're looking for a platform because your current EMR doesn't have it, please go to advancedmd.com, call their offices, let them know you heard it on the Codecast podcast with Terry Fletcher, and they'll give you a great deal. Also, for those of you looking for CEUs and you need a lot at once, I'll be speaking with 8 other presenters on a multi-specialty platform. Topics will include cardiology and peripheral cardiology. That's what I'm covering. There'll be telehealth, mental health, modifiers and global billing, ICD-10, E&M, risk management, fraud, auditing, coding, colon coding, therapy coding, anesthesia, radiology, oncology, and more. So it's going to be on demand. There'll be 12 CEUs available, and it is July 11th and 12th. So basically, they'll say it'll be available on this website. You pay for it, and immediately you'll get to have access to the links to listen to them at your leisure. It's only $119. And if you sign up before then, it'll be $89 up through June 30th, but after that, it'll go to $119. So it's at ozarkcodingllc.com. I would encourage you to participate if you need CEUs. So that is a great option for those of you that need some CEUs. Now, I don't know how they're splitting it up. If it's per session, I think it's going to be 1 to 1.5 per session, or you can get all 12 CEUs. Just depends what you need. So make sure you take a look at that. And I'll be promoting that in future episodes right up to the time we speak on that. So to end this week, I was able to get on my Zoom for a happy hour call with some of my girlfriends who we go to the wine club with. It was awesome. We sat there and just laughed for an hour and a half. I needed it so much. I forgot how much I miss laughing out loud. But shout out to my friends, Dina, Julie, Judy, and Deb. And it was just really funny because we started telling each other all of the Zoom, Global Meet, WebEx, FaceTime, Skype business fails that are going on right now. And I think I won the funniest one. Of course, Deb had a good one as well. And so I thought I'd share them with you because they're pretty just ridiculous of what's going on. So I have been speaking at AAPC chapter meetings, and I won't call out which chapter it was, but most of them have had over 110 people join. So I had one that was 85, one that was 110, one that was 115, another one that was 97. So very, very heavily attended all over the country, Texas, Florida, Chicago, Illinois, one in California. Actually, I have another one coming up in Texas, and another in Florida coming up, another one in Massachusetts. So it's pretty big right now as far as the chapter virtual meetings, but a lot of people are just new to figuring out Zoom, and Zoom is the easiest platform to do something like that. But it gives you a mic and video option, and unless the facilitator is muting everybody on the way in, then people have to do it on their own. Well, we had one gal that couldn't figure it out, and she decided that she would just be really quiet. Well, it was bad because she felt that she needed to use the restroom and took her phone into the restroom, and all of us got to enjoy the sounds of that, flush and all. So people, I've got to comment on this, okay? And you know I rant at times about professionalism. In March, we cut you some slack on learning how to Zoom, learning how to do digital platforms when you never had to work remotely before. In April, there was we tolerated the kids and pet noise in the background. But come on, we're in May. We're now 3 months into this. You have to be professional. You have to realize that you're on a call, stay professional, and if you can't, don't get on. That was a very embarrassing situation, and it was more fun retelling it with some wine in my hand. But I'm just letting you know, as funny as that was, that's not a good idea. So, one of the things my one friend Deb was telling me is that she had to get on a call with a Japanese supplier because she works for a distributor for a certain vegetable company. And she said one of the things with the Japanese culture is that it's a sign of disrespect to not keep looking at them. So you can't look down at your phone. You can't even look down at a piece of paper. You have to be looking into the video. Otherwise, it's disrespectful. And they didn't speak English. So she had to be on 5-hour call starting at 6 p.m. our time with not only the Japanese distributor on their end, but also the interpreter. So she had to listen to it the first time and then through the interpreter and talk about a stressful meeting. I can't even imagine. So for those of you that are struggling with some of those platforms, somebody else is struggling in a different way. So letting you know. But anyway, it's been a good time. I really appreciate speaking on all the different chapter meetings, and it's been nice just to see everybody and to just get out there, because I'm telling you, it's really starting to feel like isolation, and we don't want to do that. So everyone, on this Terry Tuesday, make it a great day and a great week. I'll talk to you next week, and thank you for listening to the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.